For those of you that don't know me, I'm officially the old guy in JBI now, I think. So I'm Craig. I'm the Deputy Executive Director and Program Director, Implementation Science. And I just have the privilege of welcoming you back from morning tea and introducing our second keynote speaker, who is Professor Maureen Dobbins. As Maureen makes her way up to the stage, I'll just briefly intro her. Maureen will be talking about knowledge translation among public health decision makers. For those of you that don't know, Professor Maureen Dobbins is Professor in the School of Nursing at McMaster University. It's a small regional university in Canada, I think, is that right? Yeah, some of you may have heard of it. She's been the Director of Health Evidence, which is a single source resource for high-quality effectiveness evidence and one component of a comprehensive knowledge translation strategy for public health decision makers worldwide. You have quite a modest role, really, worldwide policy leader. And that's part of the privilege of having Maureen come and speak with us today. Since 2011, Maureen has been Scientific Director for the National Collaborating Centre of Methods and Tools, which is one of 6 national collaborating centres for public health in Canada. Give Maureen a warm, coffee-fueled welcome to the stage. Thank you, Maureen.
Thank you so much, Craig. The pleasure is all mine to be here, to have the opportunity to talk about, really, I'm reflecting on 30 years of working with public health decision makers in Canada to use evidence in practice. So that's what I'll talk about. And I just thought I would start with just a few disclosures. I don't have any actual or potential conflicts. I will talk a lot about the work that we've done that's funded by the Public Health Agency of Canada, affiliated with McMaster University, and these are my opinions, not those of the Public Health Agency of Canada. And I think it's important for me to also acknowledge the land in which we work at McMaster University, and we recognize and acknowledge that it's located on the traditional territories of the Mississauga and Haudenosaunee nations within the lands protected by the Dish with One Spoon Wampum Agreement, which means that we agree to share all of the resources and look after the land while we do that. So we're very privileged to have that opportunity. And I just thought I would give you a little bit of a perspective in terms of where I am. So the little blue dot there, which is close to the border with the US, and why it's also a really wonderful pleasure to be here. 1 year ago today, so November 16th, this is what my backyard looked like. It's a little early for snow, but we are definitely heading into the dark days of winter, cold. It's not cold enough to have enough snow to ski yet. So, it's that period where you struggle a little bit. It's icy if you go running outside, dark in the morning, dark at night, and you can't do the fun stuff of winter yet. So really my pleasure to be here. So similar to Ruth, I thought I would start a little bit with telling you a bit about me and how it is I'm here to speak to you today about the things that I've learned with public health over the years. And I might just back up a little bit to say that I have a strong affinity and love for Australia that I think comes from when my grandfather, as a 17-year-old boy, really, left England on a ship and came to Australia and lived here for 5 years in the outback. I just have one picture of him on a horse with a sleeping bag rolled up, and he slept under the stars looking after sheep for 5 years until the Great Depression, and then he had to go home back to England. And I grew up in Montreal in a very city-type environment with a father, my grandfather's son, who just couldn't even imagine sleeping in a tent, never mind under the stars. But I think my grandfather's love for Australia really came, I think, skipped a generation and landed with me. And also I lived here in the end of 1992, 1993 for a year, did a little bit of work in public health, and met a woman who convinced me that I needed to do a PhD. I didn't even know what a PhD was at the time. I thought maybe I'd do a master's, but not a PhD. She convinced me I needed to do one. And I went home after the end of that year and said, I need to do a PhD, and here we are. So in terms of, it's so important, the opportunities that we have and who we meet along the way that can really send us in a direction we might not have ever thought. So I just thought I'd talk a little bit about public health to make sure you're on the same page of when I say those words, what does that mean? So in Canada, which may be similar to many of you, public health is that part of healthcare that's looking at preventing disease, promoting health, protecting health, and is funded in my country quite separately than the acute care sector. So that's what I lived in. That's, the folks that have been, of course, very, very involved with COVID that are now trying to figure out what they're doing post-COVID as so many things were put on hold and in fact, many needs and inequities really widened during COVID. And one of the reasons why I think it's important to talk about public health, which I'll show you a second in a moment, is my first job outside of nursing school was as a public health nurse. And what I learned as a public health nurse, as this 22-year-old whose job it was to go in and meet with new mums and dads who may have been identified at risk for how they might raise their children. 22 years old, no children of my own. What did I have to say to these families that I was working with? And one of I learned many things that really provided me with the skills for my entire career in knowledge translation, which was that I'm going into someone's home. That means I need to work with them on what's important to them in a respectful way with what they wanted to work on and coming from a place of humility, which was a similar word that we saw with Ruth. So those things really were setting the stage for how I've acted in my entire career in terms of working with others and really passionate about. It's not my agenda and it's not my career, it's how can the people I work with in academia help make something better for public health, which then helps the health of the populations. So a bit about me, it's 3 years of learnings, where to from here as we emerge from COVID, and then really practice, are we ready for practice-based implementation? And I'll tell you a bit more about that. And so I'm probably here in the early days, this larger fish, looking pretty worried. Again, what do I know? Right out of nursing school into public health. And I was very fortunate to end up working at a health unit, at a public health unit, that had these special positions where the health unit bought out some of the time of my academic professors in the School of Nursing to come to the health unit to help the health unit do research, as well as think about what evidence was supporting the programs that were being implemented in that public health department. And so that early modeling was there for me from basically day one of my career. So how lucky is that I ended up just with these amazing mentors that are still mentors today in my career. And everything that I've done with my career since leaving frontline public health nursing is really to help that nurse. So, my undergraduate program taught us how to critically appraise research, and I had way more, I thought I was way better at it than I probably was, but I had confidence that I could tell a good study from a not so good study. But what I was really challenged with was valuing the reading of the literature over the long list of other tasks that I perceived were valued more by my employer. So I had an amazing library. I could call the library and say, could you send me articles on X? And then a big giant envelope. Back in the day, it was all hard copy, no electronic versions to really date myself. This big envelope would show up a few weeks later. And I'd be extremely motivated and excited to jump into reading all that literature. And several months later, I might have only read 1 or 2 studies. I just couldn't find the time at work. And then I'd bring that pile home and think, well, I'll read that at home, maybe bedtime reading. And I didn't do it then either. And then it's 3 months later, and now I have another question. I'll call the librarian up again and get another pile of articles. So there was a will there. I really wanted to use the evidence, but really struggled to value it as much as anything else that I did so that I could think about how to use it. And everything I've done since has been to help that nurse. What would have helped me read the evidence? What would have helped my organization help me prioritize that? And that's what I've really just been so lucky to be able to receive funding to explore that. And a little different maybe from what Ruth said earlier around changing the way of doing business is what has kind of guided me, but with a lot of input from the business I was hoping to change. So it's thinking about, in practice, I think the way evidence-informed decision-making plays out is this EIDM stuff is extra. I've got my real job here, and the EIDM from a practitioner is what gets done off the side of the desk. And I've believed for 30 years that if we want to change that, then we need to think of how decisions are made in a different way and creating and helping support organizations that it just happens. So the systems are there, the structures are there, that this integration of the evidence into decision-making just happens naturally. It isn't this extra step or steps that people have to do. So that's also what I've been working on, is that this is an organizational issue, not just about providing capacity sharing with individual public health professionals. And so in my PhD, I looked at, by then I was well ingrained and indoctrinated into Cochrane, doing systematic reviews, evaluating what I had done as a public health nurse. And then we started wondering, does anybody read any of these? And I thought, should we get $500,000 a year to produce these reviews if no one's reading them? And at the ripe old age of about 25, I led my own first systematic review in community-based heart health interventions and was crushed thinking, what if nobody reads this? I just spent a year of my life working on this thing. So what can we do about this? So we started, my colleagues and I, doing some studies to understand, what did people know about these? What did public health professionals think about them? Explain to us, how are decisions made in public health? What are the inputs into decisions? What evidence is valued more than others? So really sitting with public health and trying to have them describe and explain to us how all of this worked. And so there was a variety of studies, quantitative studies, qualitative studies that were done to help us start to understand this. Where were systematic reviews? In what formats did they want to receive them? And really developing a lot of knowledge about how it all worked. And so one of the things I reflect on in my career is that evidence-informed decision-making is very much about trust. And it coincides a lot with what Ruth said. Building relationships. And I would add the word, building trusting relationships. I remember in my early career, because I was a public health nurse, and then I'm calling, days of picking up the phone, and people were sitting at their desks and might pick up their phone, asking them, trying to coax them to participate in our studies. And many times they would say, well, you're a public health nurse, and I believe that you are doing this for us. This isn't about you building your career and being successful. You're trying to make a difference for us. I'm going to participate in your study only because of that. So I've learned over the years that trust is built by really being present and open to wanting to make a difference in what is important to public health professionals. And I've been committed to that for many decades now. And it doesn't always work out exactly the way we hope, but when we are honest and open and doing our best with those relationships, it builds trust. And this is what allows movement, I think, to be made on that trajectory towards evidence-informed decision-making. And I'll come back to that later in my presentation about just how important trust is. And so some of you may be familiar with this paper after, several, what I thought were several studies in evidence-informed decision-making and hearing from public health all over Canada what their needs are. We were ready for the randomized control trial. So of course, I come from McMaster. We love doing randomized control trials, so I'm going to get on that and do a randomized control trial. And this was to look at knowledge brokering. I really thought that having an external person who worked closely over a year with public health units to build capacity, help build a culture, would result in some significant change in evidence-informed decision-making. And if any of you have read there's two studies. One of the results of the paper of the study, the other one is a description of what the knowledge broker was doing. What you might recall I said in, I think this was published around 2009, was I didn't think we should do RCTs in knowledge translation work. I didn't know as much as I thought I did about what was going on in knowledge translation. And I really thought of this study sort of as a failure, really. It was way too early to be doing a randomized control trial. And what we learned is when you're dealing with organizations that are all different, every single one of them are different, how do we actually make this assumption that by randomly allocating them to a group to receive knowledge brokering and the other not, that they would be equally, everything would be the same about them except for the knowledge brokering. I don't think it's possible to achieve that. And what I did also learn through this study is that every health unit that I've worked with for over 20 years now does EIDM in its own unique way and struggles to actually find how it fits in their organization and in their organizational processes. And so the intervention can't be the same because I believe it needs to be tailored for what the processes that are there and what their needs are. So again, some significant challenges to using a randomized control design. And so really since then, I've really focused on case studies to help us think about and work very closely with health units, and which also gives us some flexibility. And then I moved to this one, and this was a little bit similar to the koalas last night that were, I guess we could say, shy or maybe indifferent or like, oh no, people again. My dog does that. She's this big white fluffy dog and everyone likes to take pictures of her when we take her for a walk, and she now is very aloof and turns her head when they want to take a picture. So what I learned here is back in the early 90s, early 2000s, there was a lot of, yes, we're into EIDM, we believe in it, we should be doing it, but when you actually rolled up your sleeve and started working with people about it, there was the quietest rooms among people who would not normally be very quiet. Right? Just keep your head down, not going to say anything, because I believe in their mind they were saying, this is a senior leadership thing, and if we just keep quiet long enough, it's all going to go away. Maureen will go away, we won't talk about this anymore. And I think that was very much just like what's happening here. Maybe they'll go away soon. So we have to deal with that indifference. How do we deal with that indifference? It means we need to be sitting down and talking, building relationships to understand what the issues are. And the other thing we learned in the randomized control trial was that we didn't really know what success would look like. How are we going to measure EIDM? We're still struggling with that today. It's not about how many people downloaded the systematic review and how many people cited it and other research articles. It's what really happened with that knowledge in the decision-making process. How has it changed what public health professionals are doing, and is that change leading to changes in health outcomes or some proxy for outcomes? We realized about 2 or 3 months into the randomized control trial of implementing the intervention that our measures were not going to be sensitive enough to pick up the small changes. And one of those small changes that we heard was a senior decision maker in an organization realizing and having a discussion with the knowledge broker saying, oh, I understand. So I shouldn't be using the article in the newspaper about a study. I need to go look at the study myself. And we thought, that was a huge shift for that decision maker, and we knew our measure would not pick that up. That was really crushing to know that so early into our study. But through our failures, we get stronger, we learn. Thank goodness this was funded, because we learned so much about what not to do and what else needed to be done. And some of those challenges, we didn't know what we didn't know, but also in our decision makers don't know what they don't know until they know what they know. Complicated sentence, but it makes a lot of sense. If any of you have gone and spoken to senior leadership or others, particularly in the early 2000s for public health, they would say, we already do this. What is all this? Like, we do this all the time. It wasn't until I was able to coax a few senior leaderships to come to the week-long critical appraisal workshop, and they thought, and they really engaged. They left work, came to McMaster every day, no phones, those kinds of things. And they went, oh, I get it. No, we're not doing this. So how do we get all those decision makers to have that aha moment? We're always going to have time as a major problem. There's always too many priorities for public health and everywhere in health. And without real, true management support and modeling, it's hard to make change. And it's not just the medical officer of health saying, yes, we're going to do this. It's actually all the rest of the actions that need to happen. And as I said before, every health unit has done EIDM differently, not one. And I've worked with over 30 organizations in Canada. They've all had to find their own way to embed it. So that makes us, we need to be really nimble in how we can work with them in those knowledge translation or implementation approaches. And it was really, really, really slow. 1 year was completely not enough time. 5 years, maybe not enough time. So we have a lot of work to do. So what were some of the key things that we learned? From the practice perspective, right, it's intervening at an organizational level. Initially, we were thinking about building capacity amongst individuals. And yes, that's really important, but it needs to happen alongside organizational change. Senior management support, this isn't happening if they're not on board and really understand what it is they're buying into. Many times they say yes, they might even give money or resources, but they don't know what they're saying yes to. So there's a lot of work that needs to be done. And we found an internal champion or champions is really, really key. So I had this fantastic doctoral student who worked with us and did social network analysis during one of the studies and learned that there were these unknown peer-identified champions throughout all levels of the organization that no one knew was so influential. Like senior management would never have picked them to be the person, to be a champion, but they were very influential. So there's some really important things we can learn there. From a research perspective, what have I learned along the way? Flexibility, and I'll come back to that in a moment. Engagement. So I started very early by having public health professionals work with me to develop the grants. What do you want to do? How can we do this? What will work for you? What are the outcomes we should be looking for? So we really focused our efforts on what their goals were, and that is the key to the research working out really well in the end, if you're lucky enough to get the funding. And so then we stepped forward a few more years. We took all the knowledge from the failed knowledge broker trial. I put calls out to several health units, and I had 5 health units that co-developed phase 2 of this knowledge broker program. And even though the grant wasn't funded, they all were still willing to participate in the study, so we found money elsewhere to do the study, and every health unit actually contributed significant dollars to pay for the intervention that they were going to receive, which was something I never would have thought was possible, but because of the relationships we'd been building, that made it possible. I wanted to just point out here as well that when this grant was written, probably around 2006 or so, I found this definition of knowledge brokering, which actually comes from Land and Water Australia. This link doesn't work anymore. I checked it last time. But you were already well on your way to knowledge brokering, maybe not in health, but had that knowledge here because this was exactly what I was trying to achieve. And with this particular grant, again, what was reinforced is that this was about organizational change. And I needed to look to that literature to help me understand that, as well as experts in organizational change. Leadership, strategic direction. So some health units started saying a strategic goal is we're going to be an evidence-informed organization. Shared vision, so it's not what I want to do, it's what do you want to do to help achieve this, and how can we do that together? It's kind of ridiculous to say now, but a combination of face-to-face and virtual, given we're so virtual now, but the face-to-face is still really, really important, is we can really interact in a different way. We did individual assessments, organizational assessments, help senior management identify what their goals were and how they would assess impact. Tailored, so I had 5 health units, and every health unit had its own intervention that was tailored to what they needed and wanted. And we made them, not made, that's a terrible way to say that. We worked with them to say, pick something you need to make a decision about in the next 6 to 8 months. So it's not the most important thing you need to work on, but you need to make a decision. And now let's work our way through the evidence-informed decision-making process so that what you're working on is directly relevant to what you need to be doing sometime in the near future. So we had to intervene at multiple levels. One health unit had senior management and frontline involved and completely left out all of management. Massive mistake, because management didn't know what was going on, didn't know how much time did their frontline staff need to be involved. So all levels need to be engaged. Starting where people are at, I find actually many people have a lot more knowledge about reading studies, interpreting studies. Maybe there's a bit of a confidence issue, but they know more than they may think they do, and we need to help build that confidence and then grow from there. And then the collaborative goal setting and practicing. Just think, if you've had the opportunity to learn anything new as an adult, it probably takes, I don't know, I'm sure there's research on this, 3, 4, 5 times longer to learn it than if you learned it when you were a child. So we need to practice. And at the end of the study, we learned, and we're still learning this, we need to get back together with senior management and say, okay, now what? How are you going to keep using this information? So we don't just do the study and now, okay, we're done, 3 years is up, whatever, we're on our way, we're gonna write some papers. It's really thinking about what's next. And then we get to the National Collaborating Center, which again is one of 6 centers, was funded from the many inadequacies that were identified in our public health system the first time SARS came to Canada. And our mandate is to really help support the development of systems so that public health can make the best decisions based on the best available evidence to really help identify and achieve the best outcomes for Canadians. And from here, we've been able to do a lot more with the knowledge brokering, and we've created this knowledge broker mentoring program, and we've done, again, another evaluation of this. And some of the same themes are still coming out, where we need concrete plans for participants to share their knowledge during and after the program, embedding in decision-making processes into the way we do business. And what we learned was it didn't really matter how large your public health unit was, how many staff you had, what your funding levels were, or how close you might be to an academic center. Even very small health units still made some really positive gains by being involved with the program. More recently, we've did a rapid review and this was at the request of the British Columbia, so we did that, I'll come back to that in a second, but we were requested to do this to look at what is the effectiveness of evidence-informed decision-making strategies. And again, this idea of specialized roles in the health unit, not everybody has to do all of it. There's certain people that can do different parts. Developing processes and mechanisms to support those new practices, because if we don't embed that, then we have a tendency to want to go back to those familiar ways of doing things. And again, that leadership support is really, really key. And so from those 59 studies that were included, we thought about the COM-B model, which many of you might know about and has been used in knowledge translation research, but the findings just naturally fell into the components of COM-B around capability, opportunity, and motivation to do those things. And so under facilitators for capability, staff knowledge, skill development, barriers were a lack of knowledge, not enough time, not feeling confident in the skills. On the opportunity, it was the development of processes that required this new way of making decisions and using evidence to be a part of, let's say you have a checklist or it's something that someone's expecting. And then the motivation, putting in systems to incentivize people, your health professionals, to work in this way. And then we get to, this is back to the trust. So after, by the time 2020 rolled around, my academic career in working with public health around evidence-informed decision-making is now 20 years old. And while we were not an organization that did rapid reviews, we started within 3 weeks of COVID being declared, being overwhelmed with the requests that we were getting from public health to help them understand, find the evidence first, or there were some questions around, I've been asked by my health unit to synthesize the evidence on X related to COVID. Could you take a look at my research question? Could you give us feedback on our search strategy? And I thought, well, maybe we could help with the critical appraisal. And then 2 weeks later, we were told, well, actually, I've been redeployed. No one's left in public health to actually do syntheses. We fell into that. But that would never have happened if we hadn't been developed that trusting relationship with that sector for many, many, many years. And just as Ruth said, who did you turn to during COVID? For us, I think a major factor of success is the folks we've been working with for years naturally turned to us to say, will you help us? And we said yes. And we were very lucky. My funder said, forget about what you said you were going to do whatever you can to help our response to COVID, which was absolutely instrumental in us being able to pivot to do that. And so 98 rapid reviews later, and we tried probably unsuccessfully more often than not, to not duplicate what others were doing. So if we had a question, the first thing we did was try to find out, is someone already working on this review? If yes, we put them in touch with that person, so the connector role. If we couldn't find a review already done or a well-done review, then we would say, yeah, we'll do it. And what we've done some evaluation of that to find out that decision makers valued that service, have used it, but again, trying to really measure what did use mean is really, really, really tricky. And now we still are receiving requests, as many organizations, to look at topics non-COVID. So just a final few slides here, are we ready for practice-based implementation, and what do I mean by that? And so Ruth, pointed out, at many conferences I've been to, I wasn't at Ottawa, but I heard this happened at Ottawa. There's a lot of talk around the living evidence, whether it's systematic reviews, the living guidelines, and I'm more than a little concerned that the focus is too much on the evidence piece. And so I provide this as the way I think about it. So most of you would know that when you see an iceberg, the part you see above the water, even though that can be massive, is about 10%, I think, of the actual size of that iceberg. And for me, the evidence part, or if we think about even just the science evidence, is that small part above the water. The very, very, very hard work of getting that evidence into decision-making, changing practices, is that 90% below. And I'm very concerned right now that our governments around the world are convinced that more and more money needs to go into the living evidence, but I don't see a lot of talk about 90% of resources to go into putting the evidence into practice. And the research to me is taking over in terms of we need to do more studies. I'm not disagreeing with implementation science, but where is the doing happening? And a call to action, I would have said to the question, what's the call to action, is if technology can produce for us, which I believe it will soon, reviews in days, maybe minutes, and I think that's coming faster than any of us might want to admit. I think it's coming. Then almost all of you can be helping me with this 90%, and that's where I think we need to have a lot of our resources. And we just did a little bit of looking into what's there in the literature. And so we did a search that goes back to the year 2000, looking for reviews in knowledge translation, implementation. And we found about 1,400 reviews. And just looking at the first 100, we found all of these reviews that are quite relevant, and there would have been many more. So all to say that we have piles and piles, enough research to fill this room studying implementation over the last 30 years, and it's time to really use that knowledge. We have the knowledge to start working, to be well into our working on that 90% of the iceberg. We also did an environmental scan recently of what we were calling knowledge translation hubs. And the reason why we did this was because the Public Health Agency of Canada, they had come to me and said, we'd like you to do a scan to see what others are doing, because we're planning on building a portal to put all of these resources into one place. And I kept saying, oh my gosh, please don't do that. They're going to spend millions of dollars building a portal, and I was trying to convince them. I think there are portals out there already. Why do you need to do another one? So this scan, which is not, it's more Canadian-centric. So it's you definitely, would have criticisms to say, where's mine? That, I definitely recognize that. But it did prove that there are many portals that are hubs that are out there, that we need people using those, not creating new ones. And we found 104 websites. Probably 3/4 of those are housing repositories on the theories, frameworks, and models of knowledge translation. So I just question us to say, how many more of those do we need? Let's get the ones we have being used. And so where to from here? Last slide. Where to from here? There's many, many forms of evidence, and particularly in public health, my public health partners will say, we listen to what our communities say and what they need and they want. That's as important as the science. We have to think about what resources we have. We have to think about the political will, the societal preferences, as well as the science, as well as looking at what does this look like with respect to the surveillance data that we have. And so like Australia, Canada is a massive country. And it's not a one-size-fits-all solution. What works in Toronto is not probably going to be the same intervention that's going to work in a small remote community. So science is just one piece of the evidence. Post-COVID, public health is stretched, continues to be stretched. Everyone's still exhausted. The money has dried up. In my province, the health units have been voluntold, incentivized to come up with merging with others instead of being forced to merge. They've said, if you choose to merge with another health unit, we'll give you a little bit of money. And so many of them are planning to now try to figure out how to merge with someone, with another health unit, and that's very much top of mind. And so an issue that we have is, while they're maybe convinced that evidence-informed decision-making is absolutely important and something that they need to be doing, with all these other pressing priorities, they don't know how they're going to be able to fit that in with what they're doing. I do believe that we've convinced policymakers and healthcare professionals, we've sold them on the immediate living evidence, and it won't be long before they will use their own devices to find a synthesis if the one they need isn't readily available to them today. And in fact, we have to ask, does every review need to be living in order for it to be useful for a decision maker? And as I said there, just the evidence into practice is such a huge, huge endeavor. And so just to finish with that, a health unit that we worked very closely with for the last 5 years, we just had a wrap-up meeting with their senior executive to say, you've invested heavily in moving towards evidence-informed decision-making. Where to from here for you? And so this is a health unit that's invested. They learned a lot. They've built skill. They've built capacity. And while they're very much committed to EIDM, they're saying over the next 18 months, we're still dealing with COVID. We're still dealing with many issues of programs we were not able to provide during COVID. We've lost staff, and now we also need to figure out how to merge, and we don't even know how many of us will still be employed in 2 years. So we don't know how we're going to do EIDM. So we're sitting down with them to say, well, what else can we do that decisions that you need to make about programs can be informed by evidence? So now it's something brand new we've probably never done before that we're going to try to work out with them. And I think that's the reality of many organizations, whether it's public health or beyond, in terms of where they are at. So how do we move instead of them moving to us? So I think I went over, but I'll stop there. We're not going to leave this up, but this could be our campfire. So just a month ago, that's what my backyard would have looked like, and we could sit down and have a little chat around the fire with a nice Australian glass of wine. But I guess we will move over here. So thank you very much.
Maureen, thank you so much for an amazing, really inspiring and interesting talk. And I'm so glad we get to have this JBI Ignite side chat together now as well. I've got the app open, and thanks to those of you that have been putting your questions in the app. If you haven't put a question in the app, Bianca will see you at lunch. So I know what I would rather do. I would put a question in the app. Maureen, there's just so much in your talk, and I kind of want to go away for a week and think about it now and then do something. But I wonder if you could just speak a little further to the tension that you sort of alluded to toward the end there about this tension that's at the forefront following COVID-19 around we've had more than a decade of focusing on generating evidence and thinking about the generation in real detail, not so much on the implementation side. Could you speak a bit more to that tension for us?
Sure. And I think it continues in terms of, the slogan, if you build it, they will come. And I think there is still a lot of emphasis that if we can just get the most up-to-date, most rigorous evidence, research evidence, into the hands of the right people, the right way, at the right time, that the miracle will happen and it'll be put into practice. And I just think that has not materialized in the entire time that I've been thinking about this, which is since 1993. And so we really do, just as Ruth was saying, we need to think about this in a very different way, because that thinking hasn't moved us, I think, as far as one might have thought if we go back to where we were in 1993, thinking that it's the evidence. And, I come at this from truly believed in randomized controlled trials, truly bought into Cochrane's systematic reviews, and thinking about all of that early in my career. And now that I'm, turning into the crabby old lady, it's like this isn't actually getting us where we thought it would get us. So we need new thinking.
We need new thinking. There's a question here from Dr. Amy Finlay, which is right on point for this. It's, what's your comment on the place of behavioural science implementation frameworks and models for implementation in public health?
And so that's something that definitely has been picking up speed, I would say, over the last probably 5 to 7 years of utilizing what we know about behavioral change and behavioral change models and theories to better inform how we're thinking about implementation strategies and as well as measurement. So there's definitely a place and important that we are looking at multiple areas of literature to think about how we can change our thinking about this. So definitely think it's important for us to be doing.
How do we learn the lessons of the last couple of decades? So behavioural science units are becoming big in policy. I don't know about Canada, but I know they are. Like in the UK, there's a lot of this development. So how do we avoid the same mistakes we've made with different systems and structures like evidence generation and systematic reviews becoming almost machine operations that self-sustain rather than engage? Is there a risk with behavioural science as well, that it focuses on creating determinates and rules rather than engaging with end users?
Well, I hope it wouldn't take us there. I would think that many that work in behavioral science come from a place that understands that making behavior change requires relationships and interaction and engagement. So I think the one area that I'm more than a little concerned about is this idea that we need to keep doing more and more and more research so that we know what to do. But, in my own work, with every health unit I've worked with needing to maneuver and work and partner with them to figure out what they need to do, research is never going to answer the 1,000,001 combinations that would be required in order to make change. So I think we know a lot, and we need to get in there and do the work and learn as we go and apply it as we go. I'm not saying there's no need to ever do research again, but it seems, or at least in my country, I would say it seems to be very focused on what's the fancy, new, sexy research design that no one's used before that's needed to get that grant funded. And I'm not sure that's going to get us much farther ahead than where we are now.
This is a question from Professor Lisa Whitehead about what are some new ways of working with practice leaders and clinicians in the current environment, given no one's really escaped rationalization?
That is a fantastic question. And humbly, I would say it's figuring out with that decision maker, what's your most pressing need that you need an answer to, that we could work on to embed evidence into that decision. Because if it's something that they really need to make a decision on soon, and they need help with that, then that's not like a make-work project. So for example, we just submitted a grant where there's some funding to look at post-COVID workforce, and that one of these grants will go to public health. So we have many public health partners involved and spent months in meetings with public health professionals to say, so there's this funding, there's some money, it's got to be about workforce. What will be most useful to you? Where we ended up was most of our health units will now need to report, at least in my province, to the provincial government on what they are doing to be prepared for the next pandemic. They must report that in order to get their funding the next year. So we ended up landing on that because it's something they have to do. They don't really want to be thinking about that right now, but it's something they have to do, and this grant will actually help them do that. So, and we were able to carve a little bit of money into the grant to help support their work in being involved in the grant along this issue. That helped them engage when they have many other priorities that without that they wouldn't have participated.
Yeah. Now, you and Ruth have both given really powerfully visual talks today, partly about positioning, which way are we facing? And that's a challenging question for everyone here in the room. There's a number of questions that I'm just going to amalgamate into one, which is in terms of engagement with the people that matter, leave that open. What are one or two things you learned during COVID that you hope to really be able to continue and carry forward in terms of engagement?
Well, similar to what I've said earlier, and really when I reflect, over the last 30 years, it's and I think Jack said it this morning, we have 2 ears for listening. And we need to be doing, I think, as researchers, a lot more listening, a lot more a recognition that we have as much to learn. So it is the capacity sharing, and I have used capacity development. I as well, Ruth, will be changing that, because I've benefited so much from the close working relationship with public health along my career. So the engagement to me is genuinely wanting to work with, and coming at that from a place of humility where I don't have all the answers, and I'm not telling you what to do. Let's work on this together. And I think that's absolutely 100% needed. And when decision makers believe that you are there for them, then I think my experience is then they want to work with you because they trust that you have their best interests at heart.
Yeah, I'm just going to finish with this. There's a saying that, knowledge that we create in the form of theories, models, and frameworks, it's a bit like a toothbrush. Everybody wants to own one, but nobody wants to use anyone else's. And I think the way you and Ruth have presented today just show the power that comes from setting aside some of, can I call it academic ego, or just raw academic passion, and admit that and see the true value of engagement. So thank you very much. Would you join me in thanking Maureen once more?
Thank you.